Now, coming to the UTIs, urinary tract infections, cystitis, pyelonephritis, perinephric abscess. Cystitis, remember, symptoms, frequency, urgency, burning dysuria, frequency, urgency, burning dysuria. If there was discharge, you think of urethritis. Cystitis is more common in females, much more common in females. You can consider cystitis kind of normal to have in a female. It's kind of expected. It's not unusual to have cystitis in a female. But when it happens in a male, now it is unusual. And now you have to search for a cause. Maybe this cause was tumor, stricture, stone, obstruction, stone, stricture, tumor, obstruction. You should search for a cause whenever it is in a male. But in a female, this is kind of usual. The best initial test is urine analysis. What are we searching for in urine? Are we searching for bacteria? No, you're searching for white blood cells. You're searching for white blood cells. The most accurate test is, of course, urine culture. Urine culture. You identify the organism by culture. Sonography. When to do sonography for UTI? Only when you are searching for the cause. And this is when it is too frequent in a female or when it happens in a male. Treatment of uncomplicated cystitis, and when I say uncomplicated cystitis, I mean that it is just in the lower half of the abdomen. It's a cystitis. It's in your urinary bladder, not in your kidneys, So now the standard of care is we stopped giving levofloxacin or ciprofloxacin for UTIs because we do not want to waste these precious, powerful antibiotics. So we start with some relatively weaker antimicrobials, fosfomycin, a single dose of 3 grams orally, or nitrofurantoin. Fosfomycin, nitrofurantoin are now the first line of therapy for uncomplicated cystitis. We can also think of trimethoprim sulfamethoxazole, although we know that 10% of the population are allergic to trimethoprim sulfamethoxazole. And trimethoprim, when it is used for simple cystitis, it's only used for 3 days. As I said, we keep ciprofloxacin and levofloxacin to the more complicated cases, to the ascending pyelonephritis cases. Asymptomatic bacteriuria. If you have bacteria in urine, treat or not treat. If the patient was asymptomatic, don't treat. But if the patient was pregnant, treat. The only condition where we have to treat asymptomatic bacteria is during pregnancy. What if the cystitis was complicated? How can I know that the cystitis is complicated? Complicated cystitis means what? Means flank pain, fever, chills, a patient who looks really ill. This means that you can have pyelonephritis. Or if the patient did not respond to a 3-day therapy of antimicrobials, now it is complicated. Complicated infections need treatment for 7 days. Trimethoprim sulfamethoxazole orally for 7 days, or ciprofloxacin for 7 days. Pyelonephritis, as I said, how are you going to suspect pyelonephritis? Frequency, urgency, burning dysuria, plus flank pain and fever, and the patient really looks ill. In simple cystitis, we get suprapubic pain only. Pyelonephritis, flank pain. It's a more severe disease, and the best initial test is again urine analysis for white blood cells. The most accurate test is urine culture, and we do ultrasound and CT whenever it is very recurrent in a female, or of course whenever it happens in a male. Treatment of pyelonephritis, any antibiotic that works for gram-negative bacteria. There is no place for fosfomycin or nitrofurantoin here. They only belong to the lower half of your urinary tract, the bladder only. But when it comes to the kidney, a lot of antibiotics that attack gram-negative, because the commonest organism of UTI is E. coli. E. coli is a gram-negative bacteria. So ceftriaxone, azithromycin, cipro, ampicillin and gentamicin, carbapenems, ampicillin sulbactam, augmentin, piperacillin, tazobactam. So all these can work against pyelonephritis, gram-negative causing bacteria. Perinephric abscess. You are treating a patient for pyelonephritis for 1 week and the patient is not responding. Now you will start thinking, suspecting the presence of a perinephric abscess. What antibiotics should I give now? The patient developed an abscess while he was taking or while she was taking antibiotics. Now I need to do a biopsy. I need to do a biopsy and culture and sensitivity to be able to give this patient the proper antibiotic to treat the perinephric abscess. Our case study for the UTI is a 24-year-old woman presenting with sudden urgency to urinate, frequent urination, pain with urination, and suprapubic discomfort. No vaginal discharge, so I'm not thinking of urethritis, I'm just thinking of cystitis. No fever, so I'm not thinking of pyelonephritis. This is obviously a simple cystitis. And the dipstick urine analysis showed leukoestrase positive and nitrites positive, and we're going to know the significance of these findings. What's the significance in the patient's absence of fever? As I said, this is going to exclude pyelonephritis. What's the significance of a positive leukoestrase and nitrites in urine? Positive leukoestrase, this points to the presence of white blood cells in urine. Nitrites will point to gram-negative bacteria. Nitrites, when you have nitrites, this is gram-negative bacteria in urine. So what's your overall assessment of the patient's condition? This patient probably have acute bacterial cystitis. I'm excluding pyelonephritis. And what the appropriate treatment for this patient? Remember, we start by fosfomycin or nitrofurantoin, and then if the patient's not responding, I can think of trimethoprim sulfamethoxazole. We do not start now with Cipro. We do not want to waste Cipro in these kind of infections.